Good morning, everyone, and thank you for inviting me for such a wonderful weekend. I am presenting what is the current state, and what are the plans for the telehealth at LBJ Tropical Medical Center. I don't have any financial interest in such activities, and there is no sponsorship on any sites. So next slide, please. Let me introduce you to what is LBJ by itself. We are a remote island, about 5 hours flight time to Honolulu, and we have about 150 beds, inpatient capacity that include ICU, pediatric, surgical, medical, OBGYN wards, and we have a set of clinics that service in dental, ENT, eye doctor, nutrition, diabetic, medical, surgical, ortho, physical therapy, hemodialysis patient. And we, next slide, please. There is a ongoing shortage, chronic shortage of physicians and specialists. We do not have subspecialties, and quite often, given that we are the only acute care facility on the island, we get in patients who have critical condition, and those conditions are time sensitive. Let's say stroke that requires certain amount of hours for a drug to be delivered to bust the clot. Travel is not something that we can talk about on the immediate situation. Like there is no such thing as bring a helicopter on the island and bring it back within 30 minutes and you are going to save the life. We are in unique situation given that we are in unincorporated territory with US, and given there is a shortage of physicians, we are able to get doctors from Pacific region, like with the education from Fiji, for example, education from Philippines, and given that we are still US territory, we have to follow the US guidelines, and telemedicine would be quite helpful to get us up to speed. Another thing that we are, given we are short, physicians are just burning out and they just prone to make a mistake, and those mistakes may be fatal for the patient. So it's reasonable to have a backup. And next thing, the equipment, the equipment that some of it we do have, some of it we just don't. Let's say MRI, which give us better view on the soft tissue. We don't have it. We do have CT scan, and radiologists might not be available, and we have to get someone in touch, and sometimes it's critical on time. Let's get back to the stroke. Neurologists or radiologists have to evaluate the images and give us a green light to start on certain medication. Certain equipment we do have, we just don't have necessary skills to utilize. And we have to have overview from a higher authority level. So that's all play roles. Then certain skills, certain equipment we can utilize with the real-time oversight of, let's say, surgeon doing procedure. And if there is a guardian angel looking all through the camera and can say, oh, cut here, but don't touch that structure, that would be something that we cannot improve on. So let's go to the next slide. The idea for us is to expand the service available at LBJ. With that, we will be able to save life, improve quality of life for patients after care, and provide rehabilitation for them. Next slide, please. Now I'm going to talk about first two lines, OBGYN. We applied for the grant. Thank you, Christina. Thank you, Ginger, for the help. It was on very tight schedule. However, we applied it. We are just waiting USDA answer. The grant is for the evaluation and treatment of high-risk pregnancies and to allow people to get the medical evaluation, not leaving the house. So that would be a great possibility to prevent pregnant patients to contract any infectious condition what we may encounter. The next big project that is still we are stuck with the bureaucracy. We have to talk about telestroke. Dr. Coyne helping us out on it, and he is the head of neurocritical ICU and head of telemedicine in Hawaii, and we are in talk to get our stroke patients quickly reviewed by the high authority, by the neurologists who are specialized only in neurology and critical care, and provide us with advice what would be the best next step in treatment and management of the patient. If you look at the list of participants, there is Ms. Yomamoto and Dr. Maros. They are ongoing consultants from Shriners, and I do appreciate their help. The partnership going on for good, 6-8 years, somewhere there. And they are doing a wonderful job, and we continue with them. Perhaps we would need to establish some kind of business relationship, I would say. But so far, we are just grateful to have their help. Our dialysis clinic has oversight from Dr. Musgrave, and recently Dr. Zutsu joined the nephrology group, and guys coming in on the island every 3 months. Given right now we are under lockdown, we are looking to explore possibility of live video consults, and that's ongoing, and we will just have to put it on paper how it's going to be paid. Next slide, please. Radiology is a wonderful subject for the off-island evaluation. We do have contract for mammography. The next step would be to get urgent reading on CT scan for telestroke and such. Right now, Jennifer Tarney is our speech-language pathologist, and she is certified for translation for deaf people. And she provides us with the assessment on the swallowing, and those patients who able to swallow with the training, we don't need to put a PEG tube, so we're saving cost. And she is already doing the telemedicine for the minor, I think for Micronesia Island, if I'm not mistaken. So we have some connection here. Dr. Chris Hare, he is the head of ANSGITA program, Australia, New Zealand Gastroenterology Training Association, I think. he is planning, or we spoke about, to provide urgent teleconsultation on those patients who need gastroenterology evaluation, let's say bleeding. Now I'm going to add to Dr. Higa about colonoscopy. It still can be done. The person who is doing colonoscopy still going to do the procedure. However, the imaging can be transmitted and read in real time by a gastroenterologist. So it is correct that it should be a person who is doing the procedure. However, the view of the image and evaluation of a lesion can be done somewhere else in a real time. Next slide, please. I do have, given that we are in the unique situation where we got the high speed to the island and we got fiber optic throughout the island, what can we do about utilization on the island of that bandwidth? And there is few things we can do. I'm planning to establish a cloud, the localized to LBJ, where we can share documents, work on it, establish electronic library for the new books, and we can put up a radiology imaging system, so anyone from the other clinics will be able to see it, and even if they don't have the parts that we use in-house, they still will be able to get access to the imaging in the remote clinics. That cloud would have video conferencing possibility, and right now I'm thinking about provider-to-provider video link. The next step we can establish for the EMS and ambulances, where the EMS technician will be able to send the video feedback to ER, and doctor in emergency room will be able to provide some instruction on what to do next, and that would bring the high level of care straight to the patient, and on the arrival we already going to have some resuscitation measures going on. So and then I'm thinking we can establish geriatric telemedicine in the Hope House, where we're not going to subdue our patients for the additional infection. However, we still will be able to provide some help at the bedside. And the next step, where we will expand the video conferencing to the patients, where patient can talk directly to provider, and it is step-based approach, and I want to make it as smooth as possible. Next slide, please. So we do have equipment, let's say a stress test, and Army Tropical Medical Center perhaps going to step in and help us with that testing in here. I spoke to pediatric group, and we have to have a connection to so many subspecialties dedicated in pediatric treatment. So it's going to be a big work for all of us. Next slide, please. Now, again, back. About doing procedure on a patient have a real live video link for a more experienced surgeon. Let's say we are doing procedure for a stroke, let's say for a hematoma removal. And if neurosurgeon will be able to see exactly what's going on, we may proceed straight to the operating room and perform the procedure. Same thing can be done for other subspecialties, pediatric, urology, anything where we can get the ongoing image from the patient from operative field on the screen and transmit that image in a lifetime, in a real time, then we can get a feedback right on the spot, and specialists will provide with the advices and we will continue with the procedure. Orthopedic surgery can be done same way, and it just implants to get the equipment, establish the connectivity with the specialists who will be able to help out, and then continue with the procedures. Next slide, please. Pathology. Hook up a camera to a microscope, let pathologists read it from off-island. ENT usually have the little tools where they can look inside, and that image can be transmitted. Eye doctor utilizes big screen as well, and can that image be transmitted? Absolutely. Dermatology, it's look and treat. Can be transmitted? Absolutely. Infectious disease, not that clear. However, we would love to have a contact to infectionist, because sometimes we get in patients with the antibiotic resistance, and it would be beneficial to have a link. Mental health, that's purely conversational most of the time, and follow-up would be very reasonable to have a to assess ongoing treatment and maybe change some of medication. So that's very reasonable subject that we can implement. Pharmacy, some of it going to be used or already in use just based on the telephone calls and video link, perhaps. Yes, something can be done, like utilization of the high toxic medication. So that's possible. It's just an idea. Next slide, please. Dental specialties. I just recently spoke with the chief of our dental department, and there is a few possibilities can be done. Again, as a procedure, and a orthodontist or maxillofacial surgeon can oversee the ongoing procedure and provide advice how to approach to such patient. And on a, let's say, remote island, someone can take a look of the shine the light and camera on the gums, and maybe patient can come for a dental review on a next flight, not as a medical evacuation. So it's just going to help us out on the queuing and managing patient and start treatment before even patients see a doctor, like face-to-face in real life. Next slide, please. Nutritionist and physical therapy. Everyone probably remember in 80s, it was a lot of videos with the TV programs, with the aerobics and such. Same thing. Nutritionist can assess the food, the amount, the quality, what is in, and provide advice. So it is possible. Quality infection control. Yes, there is some ideas about show me the event, and all of a sudden there is a vent full of dust. Reasonable to check? Yes, possible. Can we do it? Yes, possible. Next slide, please. I already mentioned about EMS and video link that will provide quicker assessment and quicker management of the patient from a pickup side. And we shorten that amount, that patient without different treatment and route. Telegeriatric, and as a next step, home health monitors, and especially for those who are on quarantine and just sitting and waiting, doing nothing. So relieving their anxiety as well. Next slide, please. Let me start with HR. It used to be just a phone conversation. Now it could be full-blown video link. You can have several people talking at the same time, and that would be a beautiful addition. Finance and billing department still can benefit from the video conferencing, audition, clearing houses for billing department, auditors for finances. That's the few things that come into my mind, and it can be done. And I don't see any restriction as soon as we're going to have connections. Next, please. Ideally, I would see a LBJ hospital as a hotspot for medical tourism in Pacific Basin. Let me elaborate a little bit. We are in a unique situation. We are basically an outskirt from US, have the equipment, have the specialties or access to specialties. Can we utilize it to improve care for entire Pacific Basin? Perhaps. That would require a little bit of work and a strong will to achieve that goal. And I think it's reasonable to aim high. Would you please go for the next slide? Now, roadblocks. This is go back, please. This is a touchy subject. I don't want to mock up anyone. I just want to say that there is some issues that may come up and how we're going to approach to it. And I will elaborate it a little bit. So next slide, please. We are on a small island. There is still the traditional way how family works prevail over the way how, let's say, mainland USA works. People from the same family, those families who understand the benefits of education, going to have better skills, and you may end up where a lot of people who are on a high-end position going to be from the same family. From people who are outside, it may look like nepotism, but from us, we get in proper people with the proper credentialing, and they would fit their position much better than if it would be someone who actually outside of the family and have just no credentialing at all, just sitting up in a chair. Again, back to the family, there is hierarchy where the elder have the last word to say, and it's sometimes written in stone, let's put it that way. There is a possibility for in a situation where we'll do it tomorrow, and it's never going to go. It's called Hawaii perhaps have same kind of situation where we call it island life, where, okay, tomorrow. So that would require a lot of dedication. It's not that we have to force it, it just matters that we have to recognize it and see if we can work it up. From economical standpoint of view, a lot of young people ending up their education somewhere on the mainland with the good paid job, and we essentially losing those talents. That's perhaps need to be addressed on a higher level than what it is at LBJ. Social elevation. If a young person growing, finishing up the school, what is the next step for them? How are they going to get to a position where they can implement their knowledge? Do the island economical development have a long-term goal? How to develop the island so business going to get in and persist and create jobs and create income and revenue, so we are not fully dependent on grants, but people actually have the work well paid and they're going to pay taxes and bring it back for the benefits of islanders. The situation with the land, I do understand everything belongs to the family, but it's just a poor view how so many places with the remnants of a house is staying on the island. It just sore in the eyes. Just bring someone on island, an investor, they're going to look at it, that doesn't look good. So it's just a thought. Next slide, please. Financial situation. Sometimes there is no money, you can do nothing about it. Sometimes there is money, but whoever is managing it have different priorities. And it is possible that there is no money for what we are thinking about. I do understand that part. Everyone got that ID 10T error? Okay. Sometimes the person who reached the level of incompetency and sitting in the highest chair, there is no expertise left. Sometimes people have no idea and they look very narrow. Okay, that's what I want to do, nothing else matters. And I'm sitting in a chair for the next 3 years. I don't care what's going to be in the 5 years. So that could be, that's already administrative level where, let's say it's above our pay grade, but it should be addressed. Sometimes it's lack of coordination in between departments. And let's say to implement the broadband, I have to talk to DOH, I have to talk to VA, I have to talk to remote clinic, and different people going to have different approach. How some of them going to be extremely busy, some of them just going to say island approach tomorrow, and some of them going to say, yeah, let's do it now. And that's going to be a challenge. So let's go next slide. The way how to improve the healthcare on the island, let the government receive the treatment on the island, only on the island. If they're going to feel their own personal life depends on the LBJ, they definitely going to have personal investment in improving of the situation here. And this is administrative resource. We heavily dependent on the grants, and given the situation with the finance, we are at the mercy of a bureaucratic apparatus essentially. If they're giving us the money, we are operating. If they are not, we are on a very thin layer of money. So that's about it. Thank you very much. Anyone who wants to get in touch with me, my first name dot last name at lbj.as would be the email. Thank you, and I'll wait for questions.
Yes, thank you. Thank you very much, Dr. Orleanski. That's a very comprehensive snapshot, right, of where LBJ is with so many different efforts with regards to telehealth. So I do commend you with your honesty and the work that's ahead of you. And I'd also like to acknowledge that Dr. To'oto'o is in the room. While we're queuing up Dr. Anese's presentation, if you wanted to share a few remarks, Dr. To'oto'o?
We try to keep it at LBJ. What we've always been wanting to do is expand this telehealth. And it has started from Shriner 10 years ago. Even if we just look, take x-ray and show it to them. And they have been great. And that's what we want from our location. And we have been stuck with the telehealth in the last 3-4 months. But we are getting the equipment, hopefully, thank you, Porter. And we will continue what is supposed to be have back before so we can make this easy. And that is the future of this place, and everybody else has agreed. And thank you, Higa. You've always been there, and you are the contact person to help us with the telehealth. And we have Ray here. So this is what we're gonna work from all angles. But at certain times, first, it's the health of this country and the education. And this is where telehealth, but I think that health should be right there on the top. Thank you.